everybody, and good evening. We are from the Kidney Warriors group. This is an exclusive webinar for all the ladies there who are pre-transplant, post-transplant, or on dialysis. A special webinar on request. We have two very, very important doctors, especially for us. One is a nephrologist and a lady nephrologist, and female gynecologist, because we've had a lot of issues pertaining to women's health, periods, pregnancy, etc., etc. So I'd first like to introduce Dr. Kristin, who is our nephrologist on board. She'll give us a clearer perspective of what we have to be cautious about, basic healthcare tips, and guide us through the entire process of women's health, pre-transplant and post-transplant. Dr. Kristin is a gold medalist in MBBS, and she's completed nephrology and training from the prestigious All India Institute of Medical Sciences. And she's also written many publications. She's done a lot of research and publication, and in both in national and international journals. Dr. Kristin, would you like to guide us through the topic of discussion for today?
Yeah. Thank you, Stephanie, and thank you, Kidney Warriors Foundation, for this platform to discuss a very important, yet I would say less commonly discussed topic about women's, reproductive, sexual health and menstrual issues, which is more common among those women who suffer from chronic kidney disease. And in our day-to-day busy practice, we are so worried about the kidney problem per se that we don't tend to discuss these issues, which are very important when we talk about quality of life. In the recent times, there is increasing proof that what patient ultimately wants is a good quality of life. So we as nephrologists many times will be talking about kidney function and the medicines, the side effects, and all those. We elaborate, we spend a lot of time, but often neglected aspect are these which can have a significant impact on the quality of life. So this is a platform where today we are going to discuss about some of these common issues which as women suffering from chronic kidney disease at different stages, be it an early chronic kidney disease on medical management, or a later stages of CKD on dialysis, being evaluated for transplant or even post-transplant setting. We'll try to answer some of the common questions, and we have an esteemed gynecologist with us, Dr. Shefalika ma'am. We both will try to sail you through some of the common questions which we have got from the patient groups. Okay. So,
Doctor, at this point, should I introduce Dr. Shefalika or?
Yeah. Please.
Yes. I'll introduce Dr. Shefalika. Dr. Shefalika is a consultant gynecologist, laparoscopic surgeon, Manipal Hospital, Bangalore. She is practicing exclusively minimally invasive gynecology and has vast experience in performing advanced laparoscopic and hysteroscopic surgeries. She has presented various papers and won many awards in international and national conferences. And you should all go and check out her books that she has written, various chapters in various books that she has written. Our esteemed doctor has also received the Shining Star Award by Deccan Herald Group for excellence in medical services. So over to you, Dr. Kristin.
Yeah, so welcome to Shefalika ma'am. She'll be, even I'll be learning certain things from ma'am today on the gynecological issues our patients are facing. So,
future link, Dr. Kristin.
Yeah. So let us get going. Before that, I am working at the Aster Whitefield Hospital as consultant nephrologist and transplant physician. So let us get started, and let us begin by one common question that naturally comes to mind of any chronic kidney disease patient is, while on dialysis, a lot of physiological functions are impaired. But after transplant, once they get transplanted, they ask us, can I get married? can I have a normal married life after transplant? So kidney transplantation, we say, is the best form of kidney replacement therapy, in the sense that it gives very good improvement in quality of life compared to dialysis. So quality of life includes increased energy, increased sense of well-being, your reproductive functions, your hormone levels, all those which are haywire during dialysis come back to near normal physiological state post-transplant. So yes, you can have a normal married life after transplant, and there will be medications throughout the post-transplant period. Lifelong medicines are there, which has to be taken as per the advice of your nephrologist. And after during your post-married life, whenever you as a couple plan pregnancy, much ahead you have to have a discussion with your nephrologist and the entire team of transplant surgeon, nephrologist, if there is a transplant social worker, with a social worker and a gynecologist and a high risk obstetrician. So a team of doctors should be consulted much ahead of the point when you're planning pregnancy. This is very important, because yes, you can become pregnant, okay, and in fact post transplant the fertility improves very significantly, and very early on post transplant the fertility improves. So another aspect is regarding contraception. So we'll be talking in detail about contraception. Ma'am will be talking about it. So pregnancy should be well planned, and you have to meet this team of doctors and plan your medicines, assess the risk. What is the risk you're going to the risk you're entering into by deciding to have a child, deciding to become pregnant. So it is going to be a high risk pregnancy. We'll have to monitor your blood pressure. It can shoot up during pregnancy. You can have adverse, or you can have a increased risk. You will have an increased risk compared to a normal person in terms of hypertension, what we call as preeclampsia, low birth weight of the baby. So these things should be addressed, and you should have an informed decision before you decide to have a child. And we usually say this is after 1 year post-transplant on a stable dose of medicine with stable graft function. So your transplanted kidney should be working well. You should not be having any rejection or recent increase in creatinine or fluctuations, any infection within a year period. You should have a stable, smooth course for a year, and then you decide in discussion with the team of doctors. And another important thing is your medicine. Certain medicines can have adverse effect on the unborn child. So certain modifications we do. For example, the mycophenolate, which we give after transplant, can have ill effects on the child. So we change it into another medicine. And this has to happen weeks before you are planning a pregnancy. So that becomes important. And in continuing with this, when we talk about pregnancy, another issue which comes very close to it is regarding contraception. So what are the different methods of contraception which we can advise, and when is the right time to advise or talk about contraception? When we talk about transplant, this talk about contraception should happen before transplant. That is a time when the patient meets the gynecologist as a part of the pre-transplant workup, and that is a time where this aspect about contraception in a reproductively active patient should take place. And here I would request Shefalika ma'am to shed some light on this contraception aspect in a patient who's planned for transplant. CKD usually will be facing a lot of menstrual irregularities and fertility levels are usually low, though contraception I'm sure should be advised during that phase as well, because we have seen one odd patients becoming pregnant, and of course we have to go for usually an MTP in such cases. So contraception in the setting of post-transplant and in dialysis patients, if you could shed more light.
Yeah. So just to add on a couple of things, when we talk about pre-transplant, that is on CKD patients who are undergoing dialysis, as such, we should, practically the frequency of intercourse is also very low because, first of all, we know that it's a chronic illness. They are in that depression. And when they are going through weekly 2 or 3 times a dialysis, obviously you are in a no state to have intercourse. So patients who are on dialysis, as such, the fertility is very low. And since the intercourse is very infrequent, and as such, already they are on so many medications, it is better to avoid any kind of medications in them. Since the, intercourse frequency is so low, probably we generally advise something like a barrier contraception where the male can use a condom because already the woman is bearing so many things. So at least the least a partner can do is to use contraception from their side. So I always insist on this. I always discuss this as a couple together, and I insist that the male partner should use condoms. Okay. Now, once the patient undergoes a transplant, the entire scenario changes. Like Dr. Kristin said, they become so energetic. And once they start leading normal life, probably all the problems that they were going through, even in CKD patients, if you speak practically, the intercourse is also not very comfortable. There are a lot of issues like vaginal dryness and pain during the intercourse and so many other things that they won't be comfortable. But suddenly the scenario changes and they start feeling comfortable. The natural desires may come up and the frequency of intercourse may be more. Though we are advising contraception, but then the frequency may be more. So that time, in case if the barrier contraception is not a suitable option for them, probably we can think of some intrauterine devices. Now, again, it all depends on whether they have any plans of pregnancy or not in the near future. Suppose, obviously in the first year of transplant, it's a strict contraception. They cannot plan any pregnancy. And like you said, once the kidney functions become stable, once they are on, lesser drugs, if they are stable from a nephrologist point of view to go ahead with the pregnancy, then in case if that is happening in the near future, we would still tell them use short-term contraception like condoms itself, because we don't want to take them any kind of long-term contraception, because oral contraceptive pills which contain estrogen, we don't prefer in them because, many of the times estrogen is a drug which increases the blood pressures and already, they are compromised. So we don't want to put any kind of additional risk from the contraceptive medicines. So preferably, only progesterone only pills, or even the progesterone releasing intrauterine devices, or even intrauterine devices like Copatees would be safer option for them if the pregnancy is not in near future. So basically the contraceptive option depends on their frequency of intercourse, when are they planning pregnancy, and how many years of post-transplant they are.
Yes, ma'am. I totally agree with you. So again, immediate post-transplant, we as nephrologists are very, skeptical about any IUDs again. So
Correct. Correct.
we are worried
Completely
about
agree. Yeah. Because since the patient would be on,
immunosuppressant, high dose.
any kind of infection, I completely understand. And we all know how precious the kidney is. Yes. No, I said in case if it is a very long-term, pregnancy is a long-term plan, probably they can, because nowadays, compared to the earlier intrauterine devices like Copati and all, where the risk of infection was higher, we have this newer hormone-releasing intrauterine devices where the risk of infection is very, very minimal. So, and it also induces amenorrhea in them or infrequent cycles in them, which is an additional advantage if they are having heavy flow and other menstrual disorders, like menorrhagia and all that.
Yeah. And ma'am, to add on, is it correct to say that it also depends the center at which they get it inserted and the setting I mean,
Absolutely.
Yeah.
High degree of asepsis is the most important thing when we are putting the IUCD. In fact, majority of the times when they are, post transplants, I don't even take a chance of putting a intrauterine device in the OPD setting. We take them to the OT, though we are not giving any anesthesia or anything. We follow strict aseptic precautions, and we put them on, at least for 5 days of antibiotics post IUCD. And we have some tips that we follow. We cut the thread short so that the thread is not longer and it is exposed to the vagina or outside. See, because majority of the times, if you see, the thread of the IUCD is the source of infection. IUCD per se is not a source of infection. Any kind of vaginal organisms which gain entry through those threads into the intrauterine, cavity, they are the cause for infection. So if you cut the thread short, you're reducing this thing, and you can definitely advise regarding the genital hygiene. We do have some of the local washes like lactacid washes, which are completely safe and which restore the vaginal flora, which reduce the risk of infection and all that. So whenever we put these kind of intrauterine devices, we take all these additional precautions, and we also counsel the patient to follow these precautions so that we reduce the chances of infection. I do have a couple of post-transplant patients who are on Mirena. They are doing really well. Of course, the reason for which I had put Mirena for contraception are very few, because like I said, once they start feeling good, the next thought is to think about the pregnancy. But some of the patients also have menstrual disorders in where I have put in this Mirena. They are doing quite well.
Oh, glad, nice to hear that. Because a lot of our patients come back with these menstrual irregularities. I mean, more than irregularities, excessive bleeding is another thing which we see in the post-transplant setting. So dialysis period, they are happy with very minimal or no menstrual cycles. They'll become oligomembrane
or amenorrhea.
So they have less frequent bleeding usually.
Yeah.
But then post-transplant, their cycles become haywire. They get once in 15 days, excessive bleeding. So then that is wherein I think, as you rightly pointed out, contraceptive plus for dysfunctional uterine bleeding, these devices placed in the right setting with right precautions should help to a great extent.
Very true.
Another common question.
When you need this for a combination of contraception and to treat menstrual disorders, this is the best option that you can, give it to a CKD post-transplant patient. Right.
So another common question that is asked, and it's also been asked in the set of questions I got, is post-transplant, when can I resume the sexual activity? So patients, are very worried. There's a kidney placed in the lower abdomen. And so they ask us, so many times after transplant, there are a lot of things going around, the transplant medicines, the creatinine will be checking very frequently. So this becomes a very trivial issue to even ask in the OPD. So I think this is a thing which we can try to address in the pre-transplant counseling period also, that once the scar heals, the surgical scar heals, probably in a couple of weeks' time, it shouldn't be a issue to resume sexual activity. Of course, madam, you can tell certain, general precautions in the background, that these patients are usually prone for infections. And after the local healing of the wound, which usually happens within 2 to 3 weeks, though up to a month, we say that local, the scar healing has to be looked after. So if it's a natural healing process, there's no complication, I think in a month's time, resuming sexual activity shouldn't be an issue. But are there any general precautions or general hygiene measures which you would advise?
Definitely. See, I think post-transplant, the first year is probably the most important period as far as the rejection or sepsis and all that is concerned. So, though I mean, from your side, you're saying that after 1 month they can resume, but definitely they'll have to keep certain things in mind. One is vagina is a house for most of the organisms, because as such, normally all women, they do have a lot of these bacilli, cocci, fungi in their vagina. And majority of the times what happens, pre-transplant, the frequency of intercourse will not be that great. And sometimes these post-transplant patients, they behave like newly married, women. So, since the intercourse frequency was not that frequent, so once they start post-transplant, they may be little bit prone for vaginal irritation, infections, and definitely also for some of the urine infections. So, whether they are using any other contraception or not, I would always insist on use of condoms to reduce the possibility of these infections. I would always say, please ask your nephrologist when is the right time to resume. I'm a little conservative in that because, kidney is the most important thing. So I would say that probably they can wait for at least 3 to 4 months, and effect of medicines also, how far they'll be comfortable or in a mood. See, because what I see is once they undergo a major surgery, as such, the libido comes down, the desire comes down, and there'll be a lot of vaginal dryness also, and they'll be quite uncomfortable to enjoy the intercourse. So when the situation is like that, probably they may not be in a great mental makeup to start the intercourse so soon. But whenever they start, I insist on using the condoms. And definitely, I always educate them to maintain the genital hygiene using this lactacid wash. Lactacid or V wash, which are commonly available. They're nothing but lactic acid, which actually restore the vaginal flora and prevent any imbalance, which is a cause for infections. So I tell them to, use these precautions. Probably after having intercourse, to wash the area with the lactacid or any of these genital washes, just to maintain the hygiene and to reduce infections.
Yeah, very well said, ma'am. I think when I meant 1 month is from more like a, how do I put it? I mean, there are no contraindications when we say, but you have brought about the practical issues surrounding it. I think that is very, very valid.
I think
That we have to take
more than the female partner, I think it's the male partner, because I'm sure the female partner after the transplant, the mental state and the physical state, they will not be in a great state to have intercourse, but it's the other partner where we have to insist that, this many months he'll have to wait.
True.
Otherwise, if we give the
very
signal, probably, many of the times I see the male partner may not be so understanding in, all the families.
Correct. No, very, very well taken, ma'am. Actually, we are, fortunately not faced with these questions most of the time. They don't, because we'll be talking about, we'll be talking about creatinine, fat level, so many things, even we, so they don't ask
many
us.
Of the times what happens, the patient comes alone to my room and they ask me, ma'am, please, can you tell my husband not to, have intercourse at least for another 6 months. I have had enough. I just want to relax and take it slow. This is more important. I mean, I have had situations like this. Because once we tell no, what happens is, though the women is not willing, the thing is, doctor has told what is your problem.
Yes. No.
From our side, I think.
Yes.
Of course, it depends from patient to patient. But generally, whenever I have dealt with post-transplant or CKD patients, this is what I have seen. So.
No. Very well taken, ma'am. So, so we will also follow the same henceforth. Moving forward. So the next aspect which we'll discuss about is the menstrual irregularities, which we see very commonly in our CKD patients, starting from the early stages of CKD. Of course, it is profound in the dialysis patients, wherein many times months together they don't get their regular periods at all. So there is a lot of changes in the normal hormonal axis, the hypothalamic, pituitary, ovarian axis, which happens in CKD. So ma'am can throw more light on this aspect and how to manage these issues.
If you actually look at CKD patients, in fact, you have a spectrum. At one end of the spectrum, they hardly get any cycles. They become either oligomenoric or amenorrheic because you have high prolactin levels, you have suppression of the hypothalamo-pituitary axis, like you said, they may get very infrequent cycles once in 3 months, 4 months, or they don't get cycles at all. This is absolutely fine. In fact, I always think that God should give the state to all women who are going through CKD, right? But the women are so worried that they're not getting their monthly cycles. If you see, especially our Indian women, they give a lot of importance to these monthly cycles. They feel that if they're not getting cycles every month, that means something wrong is going in their body. And, all the bad blood is going inside and causing more problems in addition to what they're suffering. But I tell them, relax. God has been very kind to you. Please feel happy that you're not having cycles. And, we don't generally give any kind of medicines to them. But the other end of the spectrum is, especially patients who are undergoing dialysis, I've also seen them having really bad heavy flow, menorrhagia, very frequent cycles, all these things, right? Again, probably because of some hormonal imbalances or some underlying causes along with the CKD, like fibroids or polyps, adenomyosis, stuff like that. See, majority of the times when a CKD patient walks in, we always try to attribute all these menstrual irregularities to, either the kidney problem or due to the dialysis or the heparin that they're receiving during the dialysis. We always forget to evaluate the patient from the gynecological perspective. So what I've generally made a rule is keep CKD aside and evaluate the patient as such, because menorrhagia or frequent cycles or severe pain during the periods is not a very common thing to see in CKD patients. So we should at least do an ultrasound abdomen and pelvis, clinical examination to see if there are any polyps or fibroids or adenomyosis. And we have to take care of those issues. And since they're already on so many kind of medications on dialysis, our treatment options are also restricted in them. So majority of the times, I try to avoid oral medications in them because either they are tranexamic acid, which I don't want, because CKD is again a state where you don't know when they are clotting, when they are, bleeding. So it's so difficult to, understand the state. So I generally try to avoid this tranexamic acid. And I would always prefer these progestin releasing intrauterine devices, what we call as Mirena in them, which is a much safer option, locally acting. Of course, there is a little bit of risk of infection that is involved. Like I said earlier, I always counsel my patients regarding the personal hygiene and all that. Majority of them, they do pretty well with these Mirena and all that. And of course, if there is any kind of underlying causes like fibroids or polyps or endometrial hyperplasia, they have to be, taken care of. Unless it's a very big fibroid or a very big adenomyoma, majority of them, they do respond well to these hormone-releasing intrauterine devices. Yeah.
Yes, ma'am. So another issue regarding, like you mentioned, that we should evaluate for core gynecological issues when patients present with these menstrual irregularities. So can you discuss a little more in detail about polycystic ovarian syndrome and endometriosis specific to CKD as well as post-transplant setting?
Yeah. See, in CKD patients or post-transplant patients, we shouldn't forget that they are also like other women who can very well develop all these kinds of hormone-related problems like polycystic ovaries, fibroids, endometriosis, and adenomyosis. Because if you see, thanks to our lifestyle and the kind of food that we are eating and the stressful environment and so many plastics and endocrine disrupting chemicals, you see all these hormone related issues so much high on the rise. So CKD patients are also not spared of it. So whenever they have additional problems like this, we have to be very careful, because if they have adenomyosis or endometriosis, it's an extremely painful condition where they'll be popping painkillers like, crazy. So I have seen women literally living on painkillers almost 2 to 3 weeks in a month, because as the disease severity progresses, it becomes excruciating pain. So, just to reduce the pain, because it gives them relief, they keep on taking. So if there is an underlying CKD, and if the painkiller consumption is so much, you're actually, putting, adding fuel to the fire. So we'll have to detect these underlying condition, try to treat them from a gynec perspective, rather than allowing them to take painkillers. So because nowadays adenomyosis and endometriosis is very high on the rise, so we'll have to evaluate all these CKD patients in case if they're having any kind of menstrual irregularities, so that we can tackle these things in a proper way, rather than allowing them to, take these painkillers. And the other thing is, if at all, if they have any fibroids or polyps or things like that, they'll be having menorrhagia with severe anemia. Already in CKD, you have severe anemia. So again, things are worsening the picture. So we should be trying to detect the root cause and treat them, rather than just, treating the anemia, which is going to worsen the problems. So if you see PCOS, which is a very, very common problem, because, almost I would say 30 to 40% of our women have PCOS. So PCOS, the problem is it also has long-term long-term health issues like diabetes and hypertension, so which they're eventually going to develop. And if they have any PCOS and obesity, we have to educate them that if at all, if there is a CKD, future development of hypertension and diabetes is going to worsen the situation and make their kidneys fail much earlier than anticipated. So suggesting them to lose weight and, follow a good, healthy lifestyle, eat healthy, all these things, we should be taking care of.
Yes, ma'am. So that is about specific gynecological issues, which, as ma'am rightly told, has to be addressed in addition, in parallel to CKD management. So as nephrologists, we very commonly we are faced with these issues of patient complaining about whether our irregular periods is because of kidney problem. So in simple terms, yes, kidney diseases can cause these irregularities and abnormalities of menstrual cycle, but we have to always, as ma'am rightly pointed out, try to find any treatable additional cause and address the same. Going forward, now talking about menopause, like many of our patients are in the more than 50s, 60s, they get transplanted. Whether early menopause is common, and how to manage menopause in the post-transplant setting and in CKD setting.
Yeah. Early menopause is definitely seen in CKD patients as well as post-transplant patients. As such, menopause is a very difficult situation to deal with, even for normal women, because they're unable to understand what's happening to them on a daily basis. Some days they are in good mood, some days such low energy levels, lot of non-specific symptoms like, aches and pains all over the body, constant tiredness, sleep disturbances, mood variations, which are already existent in the CKD patients. So this is again, it's worsening the situation. So we have to be really patient with these people, because majority of the times, the situation worsens once they are going towards the menopause. I'm talking about the CKD patients. So probably in them, it's only the improving their lifestyle, Unfortunately, we cannot advise them like other women to take more of fruits and vegetables and to take soya and all that. Unfortunately, we cannot advise them. So probably we can, put them on estrogen gel, which is a much safer alternative, because obviously oral estrogen containing hormone replacement therapies are a big no because of their own thrombogenic issues and hypertension, diabetes, and all that. So if the symptoms are really, really bad, all these hot flashes and all that, sometimes I hear patients, they have hardly would have slept for months together, because this troubles them so much during the night that everybody is peacefully sleeping and they just wake up with, as if they have taken a shower, and the dress being entirely wet and all that, because of these episodes, which are quite common in the night, unfortunately. Disturbed sleep adds to the other problems of tiredness and low mood, low energy levels, and all that. So if the situation is really bad like that, we have a lot of options like, isoflavones, which are a little safer alternative, or estrogen gel, where you don't have the systemic absorption of estrogen, definitely can give some relief to them. Of course, even when it is a physical activity, we can't advise them again, like other women, to go for a high intensity activity or things like that. Because as such in CKD, because of their physical this thing, probably they may not be in a position to do high intensity activity, but we should definitely encourage them to do some light walking or light jogging for prolonged time, and doing some meditation, deep breathing exercises, simple stretching, yogasana, and all that. And to, more of social activities, talk to many people, join some laughter club, have their own group of friends, so that when they share their stories with others, they feel little lighter. So these kind of emotional support is very, very important when they're going through the menopause.
Yeah. So I think same is applicable even in the post-transplant setting. We cannot really use these hormone-based systemic therapies. So mostly it will be the local hormone-based therapies, if at all, which can be used.
Yeah. And osteoporosis is again one more major issue, because when the menopause sets in, osteoporosis is already existing in CKD patients. So this is going to worsen. So probably some calcium supplements and all that should help them.
Yes. So moving forward, so we have discussed about issues of menstrual irregularities. We have discussed about in general sexual dysfunction, sexual health, how to when can you resume after transplant, contraceptive methods we have discussed about, pregnancy briefly we have touched upon. Anything regarding pregnancy you want to add on, ma'am, in the post-transplant setting?
Yeah. See, as such, we all know that pregnancy involves a huge change of physical, chemical, hormonal, and a lot of biological and mental, psychological changes. So in a transplant patient, these are an additional burden. So a very supportive family and frequent checkups by a high-risk obstetrician who is well-versed in managing these post-transplant patients, because many times pregnancy symptoms and, any of the other kidney problem symptoms may mimic. So the very important is to consult an obstetrician who is a specialist in dealing these post-transplant pregnancies. Now, that's an important thing. Otherwise, I think they are in a stable state, and if the nephrologist has already put them on a safer medication, I think it should be fine.
Yeah, I think as you rightly pointed out, they should understand and they should have a strong support system, and they should know beforehand what they're entering into.
Yeah.
So many of our women, like you said, after transplant, the kidney functions are normal, they feel normal. The next thing they want is a baby.
Yeah.
Without really understanding what are the things, lot of changes happen even in a normal lady who becomes pregnant, and motherhood itself has its own challenges. So in a patient who has got a transplant done, what they are entering into, what are the implications, what are the possible complications. All these things should be discussed in detail. And as nephrologists, we tend to discuss mostly about the transplanted kidney and related complications, and a close discussion with a gynecologist gynecologist and an obstetrician who's well versed in handling these issues becomes very important. And in the same flow, let us discuss also about unwanted pregnancies, or accidental pregnancies while the patient is taking medicines which could potentially have teratogenic effect or ill effects on the unborn child. So how to go about it?
Yeah. So the most important thing is to educate them that if at all, in spite of using contraception, if at all, if they miss the period, they have to report to the obstetrician as early as possible, because irregular cycles is one more problem where they keep on thinking that, they may get cycles because they keep getting once in 1.5 months, 2 months, things like that. So many times I have seen that they'll be anticipating that they will be getting a cycle. So most important thing is to instruct not to wait for too long to get the cycle, and to do at least urine pregnancy test at home itself in case if the periods are delayed for more than 1.5 to 2 months. And if it is positive, to report to the obstetrician at the earliest, because the earlier they come, easier it is for us to go for a medical termination. Because obviously, if they're on all these drugs, continuing a pregnancy would not be a possible option, because then if at all, if we are resorting to the termination of pregnancy, ideally with the medical method, that is just using the tablets, would be the ideal option for them. So for that, it is always better if they can report to us at a very early stage. So we would just do a scan, and thanks to the medical termination pregnancy medicines, which are quite safe, with a very high success rate of almost 90 to 95%, so that we are avoiding a surgical procedure in them. I think this should be a possible thing. Yeah.
So till now, whatever topics we have discussed, I think the next one which needs to be discussed is regarding cancer prevention, vaccination. So it's a little different topic, I would say. So till now, whatever we have discussed, if we have any questions from anybody, I think this is the right time to have it, and we can discuss. Stephanie, do we have anything, or from your side, if you have anything?
I think the topics have been covered more or less actually beautifully, because these are the main issues that we as post-transplant and even the ones on dialysis face, like the ones you mentioned about emergency contraceptive. I think that has been one of the main concern, because while we understand, pregnancy is not just, like a blessing, it requires a lot of planning, as you can put it, that you have to keep about 2 months provision to plan. You have to get in touch with your gynecologist, your nephrologist. There's a certain change in the medication. There are a lot of tests involved. So yes, that's a good topic to cover. Some of our fellow members actually have concerns about weight post-transplant. And I think, it could be directly or indirectly a result of transplant medication. I'm not sure. Like Vicilin, for example, gave a lot of people freckles and pimples and stuff like that, hair fall.
Yes.
So some of our fellow members have addressed weight gain post-transplant, weight issues. They're not able to lose weight. Is there any specific diet that you could recommend, or any exercise to help keep, to be fit and healthy?
Right. So CKD, dialysis is a stage wherein the appetite is poor, you're not eating well, you don't feel like eating. And then after transplant, you feel your appetite returns back. And in fact, we very commonly see that patients gain weight in the initial 3 to 6 months. And it is a healthy gain in weight. But again, our medicines can cause weight gain per se. And there is a risk of developing diabetes post-transplant because of the medicines again. So having a healthy diet is very important at every stage, and it becomes more important post-transplant, because during dialysis, we are mostly talking about restrictions in terms of certain items, but we encourage protein intake. We usually encourage caloric intake because appetite itself is poor. But post-transplant, you have to follow certain restrictions in the form of avoiding high calorie, sugary food, which can, have a tendency to develop diabetes in you and can also cause weight gain. So this on a case-to-case basis, some patients are so emaciated during dialysis, lost a lot of weight. We encourage weight gain in the initial 3 to 6 months. We have seen patients gaining 7 to 8, sometimes up to 10 kgs after transplant, which is a healthy sign. Again, there are certain patients who become obese, or they develop abdominal obesity, more of fat deposition, or an unhealthy weight gain. So it has to be seen on a case-to-case basis. But yes, in general, the medicines are diabetogenic. It can induce diabetes in you after transplant. It can cause weight gain. Steroids especially are known to cause certain skin changes, acne, striae. These are common with steroids. Nowadays, we try to taper off steroids early on. Within a month, 2 months, we try to bring it down to a bare minimum dose. And nowadays, even there are centers using steroid-free protocols wherein steroids are completely taken off because of these ill effects of steroids itself. But by and large, most of the Indian centers, we tend to use or continue small dose steroids lifelong. The side effects are usually in the initial 2 to 3 months, wherein the high dose steroids are used. Yes, it can be a concern, especially for women because of the cosmetic reasons, but can be handled with certain basic, skincare regime, and sometimes we involve the dermatologist. So it is manageable. Weight gain, yes, you have to watch your diet and follow a healthy diet.
Okay. So doctor, the next question is in lines of many women are also experiencing spotting. So this spotting of blood is coming at the ovulation period sometimes, or at the start of period itself. So in our women's group, a lot of women discuss about this unplanned spotting coming in, and they're very concerned about what does it mean for them and their period health otherwise. So many specific questions are also coming, but I'm not going to detail for the lack of time. But just generally, what does this spotting mean, and how it's very common with, especially in our post-transplant group. So would you just shed some light on that?
Yeah. See, during CKD, the ovaries would have got completely suppressed. Okay. And once they post-transplant, because overall health improves, the ovaries also become active. And, suddenly the egg release happens. That's why you see the unplanned pregnancies also, because they will be in the same mental state that all these years I didn't have anything. But now they don't realize that after the transplant, the uterus becomes active, the ovaries become active. So all these hormonal changes which happen in other women, other healthy women, keep happening in post-transplant also. See, if you see in generally in all women, any kind of premenstrual and post-menstrual spotting for about 3 to 5 days, or spotting during ovulation, is absolutely normal. This is, a part of the hormonal imbalance, which can also be seen in post-transplant women. Suppose if the spotting is not just confined to the pre and post-menstrual period or during the mid-cycle during ovulation, if it is prolonged spotting for more than 2 weeks, 3 weeks, they have to get an ultrasound pelvis to rule out what is called as an endometrial polyp or an endometrial hyperplasia. So any spotting which is continuous for more than 2 to 3 weeks needs evaluation. If it is just for a couple of days before and after menstruation or during mid-cycle, I think they can just ignore.
I have a question, doctor. Coming to spotting and post-transplant. So I noticed, I was in Bombay for about 5 years. And because of work, stress, and plus we are either ways on medication, we are on high level, I don't know, probably cortisol levels are pretty high in our body. Does that in a way impact spotting as well? Like you've said, spotting is normal for a CKD, either on dialysis or post-transplant, anywhere between the 14th day from the period. But it shouldn't be, I think, for about 2 weeks. This is what you've mentioned.
Yeah.
would it also include physical activity, in the sense, if I've noticed something whenever in Bombay, I was very tired. Let's say I would be very exhausted physically and mentally. I've noticed spotting between cycles.
Yeah. Yeah.
So that is normal.
Definitely. See, if you see the menstrual cycle, whether it's the frequency, the amount, the spotting, the number of days of all these spotting, they are related to your activity levels, stress levels, the kind of food that you're eating, the traveling schedule, the change of place, the weather, so many things, But we cannot assume that it is because of that. My saying is, yes, of course, it could be just a physiological change because of so many things that you're going through. Even a professional stress itself can cause prolonged spotting. Okay.
Understood.
But instead of assuming that it could be because of all these things, always better to get a scan done, rule out the other possibilities. And then if everything is normal, we can attribute that, it is due to these stress levels or change in activity levels and try to correct them.
Understood. I have another question, Doctor. This is from a fellow member from the Kidney Warriors group. How do we know we've reached menopause in dialysis patient?
Yeah. If you don't have any periods for one complete year, tells you that you have attained menopause. Okay. Sometimes I've seen that patients who are on dialysis have a lot of irregular cycles, infrequent cycles. They may not bleed for about almost 10 to 11 months and they may start bleeding on the 12th month. It is still not menopause. So absence of menstruation complete 1 year is called as menopause.
If there is, if we are on time, we can have one more question. Otherwise, we can take up towards the end. I mean, as per the doctor, we have one more question on eggs required for a woman to have periods on those lines. I mean, related to menstruation. If we have time, we can take that up.
Yeah, I think ma'am can quickly clear that and then.
Yeah.
So the question is, it is said that the number of eggs required for a woman to have periods are generated during gestation period itself. So her question is that if a dialysis patient is not having periods for a couple of years, or so would the eggs not undergone ovulation or not undergone through periods, would it add up to any complications later?
Okay. See, there are certain number of eggs that our girl child is born with. Okay. And every month it keeps getting released. In dialysis, what happens? Because of lot of hormonal imbalances, the ovary gets suppressed. It is unable to release eggs. That's why you don't have the periods. Over a period of time, all those follicles will undergo atresia. It is definitely not going to cause any health problem to them.
So we'll have a small discussion on the last topic of concern, which is regarding cancer in women, gynecological malignancies, post-transplant in specific. So after transplant, as I mentioned, patient is on immunosuppressive medications. So immunosuppressive medications can increase your risk of cancers in general compared to the normal population, which is a known fact. So the reason is that in a normal healthy individual, there are these immune cells which act like, watchmen, or you can say they do a patrolling of your body for any abnormal cells. And if any tumor cell, even a single cell is formed somewhere in the body, they recognize, they go and kill these cells. So because of immunosuppressive medications, this ability of the immune surveillance, what we call, is suppressed, and you have a certain increased risk compared to the general population. Having said that, we don't see malignancies in such huge numbers post-transplant in our population, but screening is always advisable to pick up cancers, if at all, in the early stage. As we know, oncology and the cancer science today has developed so much that cancer has also become another chronic manageable disease. The key is to pick it up early. So what are the cancers we advise screening for? For this discussion purpose, we'll limit to gynecological malignancies or cancers specifically in women. So the two common cancers in women are the breast and the cervical CA, and the guidelines in solid organ transplant or kidney transplantation for screening, advocate a screening either an annual basis or once in 2 years with a mammography and a pap smear. That is what the guidelines tell. I'm sure Shefalika ma'am can throw more light on this regarding cancer screening in the post-transplant setting.
Yeah. So anyways, they will be on regular ultrasound abdomen and pelvis, which will cover uterus, fallopian tubes, and ovaries screening. When it comes to the cervical cancer, what we have is, along with the pap smear, the commonly used screening test, we also do HPV DNA typing. So when you do a pap smear with a HPV DNA typing, your risk of developing cervical cancer for another 5 years is already predicted. So you don't have to do an yearly pap smear like earlier if you have done a pap smear with a HPV DNA typing. And I would say in a younger patient who is, post-transplant or whatever, always advisable to, vaccinate them against the cervical cancer. So this is the only vaccine that is available against a cancer. So I would suggest, since they are immunocompromised, and since 99% of the cervical cancers are because of the HPV infection, vaccinating them would definitely, make sense. So all these people have to be educated about the availability of cervical cancer vaccine, and wherever there is an opportunity. In India, FOXI recommends vaccination from 9 to 45 years of age. So women in this age group have to be, vaccinated. Apart from that, the breast, of course, now the CA breast stands first in the list in malignancies of women. So probably one baseline mammogram with an ultrasound breast is definitely required, followed by yearly ultrasound breast. If at all, if there is any family history of breast cancer in them, then definitely once in 3 years mammogram is also indicated. But more than anything, every woman has to be taught self-examination of the breast, because we always advocate screening once a year, and 1 year is a too long period. Anything can happen in that. So every woman should be taught how to examine their breast every single month. They can fix it up a day soon after their cycle, and with the palm of the hand, they have to, go clockwise, palpate all over the breast, squeeze the nipple and see for any discharge. So this self-examination of the breast, whenever any of the patient walks in, I always teach them, which can definitely be helpful.
Very well taken, ma'am. I totally agree regarding sensitization is very important in our patients. Many times we miss out on explaining these things, which nowadays we see post-transplant patients going on for 10, 20 years. And then these issues, come up. So counseling early on and having a fixed time, monthly self-examination, and then an annual or once in 5 years screening, having it fixed in their schedule of visits is probably important.
Because I have seen 2 times mammogram has been done for a patient, reported as a normal. Patient came to me to show the mammogram report. I always, make a point of doing an examination of the breast, picked up a lump, sent for a second opinion. And when they correlated with the ultrasound, then only they could found a suspicious lump. When biopsied, it was a malignancy. So plain mammogram can always miss. So a mammogram has to be correlated with an ultrasound. And we cannot underestimate the self-examination of the breast.
Yeah, that's a point very well taken. So sonomammogram, we do baseline in the pre-transplant evaluation, which we do. Yeah. And then after that, somewhere it tends to get missed. So I think it has to be again reinforced. Yeah. And as you rightly told, self-examination has to be stressed upon. So vaccine, madam already mentioned. So HPV vaccine is the only vaccine against cancer, and we should all, I mean, as nephrologists, again, a point I admit that we do not stress upon. We discuss about all other vaccines, especially in our dialysis population. We meticulously vaccinate against a lot of other hepatitis B, now even we have included varicella herpes vaccine, which is newly available.
In fact, CKD is a high risk for developing a cervical cancer. Because of the immunosuppression, higher chances of HPV infection, and it's one of the risk factor for cervical cancer.
Yes.
So,
I think it's a learning point for me as well. We should stress upon more regarding the HPV vaccine in our CKD dialysis and also in the post-transplant setting. Yes, so I think we have come to a conclusion of regarding the questions which were posed. Anything else we need to discuss? Any other questions we can? Yeah.
Just the last question. Thank you so much. It's been a highly enriching and a very educational session. I mean, both for Merlin and me, sorry, and I'm sure a lot of fellow members, ladies especially, because what happens is once, you have a transplant, it's not just, okay, no dialysis after that, but there are a lot of other things that we get accustomed to slowly and gradually, with number one, getting familiar with the side effects of medication. Number two is getting to know how your body responds to the medicines a certain way. Like a weight gain for somebody might not be a weight gain for me, but it could be something else. So it's an ongoing process and an ongoing journey, of course, and we learn through the years. Coming to vaccination, having Dr. Shefali mentioned the importance of getting the vaccine, the cervical cancer vaccine taken. As nephrologists, would you suggest it as a compulsory or a mandatory vaccination for us post-transplant patients?
So, yeah, we have not included it as a mandatory vaccine, but again, it is something we should offer to all post-transplant, in fact, pre-transplant patients as well. It is a safe vaccine. So the vaccine.
When you say, doctor, when you say pre-transplant, would it also apply to patients who are on dialysis? Like
yes,
who are
yes.
on dialysis? Okay.
Yes, we can offer in the dialysis population itself. If missed in the pre-transplant period, it can be given in the post-transplant. In the post-transplant, only vaccines which we ask not to take are the live attenuated vaccines.
Okay.
So,
in fact, the vaccination schedule starts at as young as 9 years, Stephanie. So, yeah. And the government of India is seriously thinking about making it as a universal vaccine. See, all these years, the cost was very high. The Gardasil 4, which was there earlier, used to be around, I think, 4,800. Then came the Gardasil 9, which was about 10,500. But thanks to Serum Institute of India, now we have the Indian version of that Gardasil 9, which is only 2,000 rupees. So, and the government of India is planning to reduce even further and planning to make it as a universal, recommendation. So I would strongly suggest all women who are sexually active, they have to take this vaccine before the first sexual exposure, because you get 100% protection only if you take before the first sexual exposure. The later you take, the efficacy comes down. But what I always tell my patients is, you spend so much for other things. It's a matter of only a couple of thousands. So, and if something is there to prevent a cancer, definitely I would insist and, strongly recommend it to all of them.
Very true. Thank you so much. And I think India is being gradually more sensitized towards important issues like cancer, women's health. Because back then,
thanks to Poonam Pandey also, who made it so popular.
Yeah, I think what she's done is that was like a masterstroke when it comes to marketing. And I think more so in her favor, but at least it's brought up this whole topic of cervical cancer and the importance of it. I think back then in school, when we were children studying in school, cancer, period related issues were not openly spoken. These are topics which are very socially sensitive till date. Whenever you go anywhere, they won't really they would wrap the sanitary pad sanitary pad in newspapers. But I think now slowly and gradually the perception is changing, and I think the more sessions that we have would be better for us, not just for women, but also for men who would understand their mothers better, husbands understanding their wives better, even brothers understanding their sisters better.
Yeah, and even in our own group with post-transplant women, we have so many questions coming in daily. And I think this session has covered mostly, at least the basic part of it. So at least everyone else of us will be a bit settled now. Now, hopefully, they'll all be saying you for the next session because there are questions that are coming in again and again. So it was really helpful. Thank you so much.
It was really nice interacting, Dr. Kristin, Marilyn, and Stephanie. Yeah,
Thank you
thanks
so
for the
much.
opportunity.
Yeah.
Thank you
It
so
was
much,
wonderful.
Dr. Shefalika, Kristin. Yes.
Yeah, bye.
Thank you.
Thank you.
Thank you.
Okay.